Orbit and oculoplasty cases. Next, I'll be talking on how to document corneal and ocular surface problems. I'm Dr. Kalpana Suresh from Chennai. We have no financial interest to disclose. The history of art of drawing started way back in 1969 when Schepens introduced how to draw retina cases. And these two are nice articles about corneal drawing, that is BJO in 1973 and in Archives in 1977. This is the base, and this was the first article published about documenting. You can go through if it is possible. So why are we to draw? So it gives you a standardization of documents. It's very easy to follow up whether the patient is progressing, deteriorating, or status quo. It's used as a teaching material. It's much cheaper. What you all need is just a few glass marking pencils. It's erasable. It improves, this is very important, it improves definitely the observation skills of the observer and also the slit lamp viewing skills. And compared to digital photography, this is much cost effective, and you can repeat any number of times, and you can enlarge and document the area of interest alone. How to draw? These are the color codes which I'll be talking about. Each color is used for specific conditions. Black, usually we use scars. Black is used to depict scars. Scars, you all know, it can be superficial or deep. Superficial scars like nebula and macula, you use light black, that is a sort of gray, and full thickness scars you use dark blue, black. All degenerations are depicted in black. Sutures are used to draw in black, that is broken sutures means you draw in broken line. Contact lens again you draw in black. Centration is very important. You shouldn't draw just around. You have to know exactly the fitting, especially for RGP lenses, whether it's perfect fit, high riding, low riding. The case sheet, you have to document what the patient's fit is actually. IOL again in black, foreign bodies in black. And if the patient has any tissue adhesive, there is cyanoacrylate glue, again that is drawn in black. So these are the color code for black. Blue depicts edema on water. Epithelial edema you draw in blue circles. Number is important. Location is also important, because if it is localized, that means this pathology is local. So if there is any localized edema superiorly close to the incision, you think of some localized pathology. Don't fill the entire cornea with blue circles. So whatever you see in the slit lamp, you have to draw. You have to have your case sheet just by the side of the slit lamp and draw. You cannot remember all the details, so don't make the habit of seeing in the slit lamp, coming to the desk and drawing. So have the color pencils, have the case sheet near the slit lamp. As and when you see, put it in the case sheet. Stromal edema is uniform, blue shade. Denser the darker. Mild edema you use mild blue. The same pencil you put a darker shade, it will indicate denser edema. Descemet's membrane folds are also drawn in black, blue, vertical blue lines. Yellow for pus. Infiltrate you draw the denser the darker, especially in microbial keratitis. Hypopyon, the height is important to monitor for the progression or whether the patient is responding to your therapy or not. Keratic precipitates are also drawn in yellow. Also the lens changes, that is cataract. Green is for fluorescent, that is epithelial defect. Morphology of the defect is important. Fluorescent staining is marked in green. Only the outline you have to mark, not fill the entire ulcer or entire lesion in green, because you can't draw the other details. SPK is again in green. Filaments either you can use green or red, because they stain both with fluorescent and rose bengal. Vitreous again in green. Red for blood. Blood vessels, superficial or deep. Sight is important. Superficial, they cross from the limbus, go on to the cornea. Deep, they start within the limbus and they are in a dichotomous branching. So gauze vessels you draw on broken line. That is blood vessels without no without any blood in it, you draw on a broken line. Hyphema again in anterior chamber, it's drawn in red. Filaments either green or red. Rose Bengal staining for ocular surface, use red. So this is the Van Westphal scoring for ocular surface disease. You divide the entire ocular surface into 3 parts: nasal conjunctiva, cornea and temporal conjunctiva. So in each you have scales from 0 to 3. 0 is no staining, 1 is mild, 2 is moderate, 3 is severe staining, as I was shown in this picture. So scale of 0 means ocular surface is healthy and intact. 9 means it's extreme staining of all the quadrants. For this you use red. Then brown again is iris and pigments. Sight is important for pigments. You can draw iron lines, epithelial melanosis, Crookenberg spindle. Iris again is drawn in brown. Pupil margin is in brown. And peripheral anterior synechiae, you draw a sight of or number of clock hours of synechiae parallel to the limbus, away from the limbus. So here you can see the superiorly the peripheral PAS. So with this picture you will know that amount of iris is attached anteriorly. So you have to mention the clock hours for PAS. So having known, you draw the frontal view first, slit view next. Finally you do the staining and draw, and always you have to take the measurements in order. So as soon as you see the lesion, you don't pour all the stains and mask all the findings. You have to document all the findings, because once you put the stain, it won't reveal, it will mask so many findings. So you will miss so many findings. So staining has to be done at the end, and you have to do all the measurements. Okay, frontal view, what you are going to draw, a pupil, a circle, that is a limbus. Outline all the opacities. Use sclerotic scatter or a diffuse torch illumination so that you don't miss any findings. How do you differentiate a scar from an infiltrate from edema? So if you pass the slit lamp, the slit section onto the area of interest, if it dazzles your eye, if it increases the reflectance, it is a scar. And in infiltrate, it will be a little yellowish. You will see plenty of cells above and below the slit, indicating a lot of inflammatory cells are pouring into that lesion. In edema, it will be uniform ground glass appearance. So you have to know what you are dealing with. You should not mistake a scar for a healing scar for an infiltrate and initiate active therapy. Okay, so this 3 things, it comes by experience, and you can always compare the slit above and below the area of lesion to compare your thickness or whether there are any inflammatory cells or not. Always there be an area of clear cornea. Most of the cases you can compare quickly the normal cornea and the area of pathology. After that you can add vessels if they are there, and then pigments, descemet membrane folds, edema, etc. So if there are too many details, you can split the entire cornea into 4 quadrants: nasal, temporal, superior and inferior. And each quadrant you start drawing and complete the process. Sutures again you have to draw, BCL, adhesives, and if there are findings in the lens and vitreous, suppose vitreous in the anterior chamber, vitreous touching the wound, vitreous touching the vitreous cornea, you draw separate sections. Separate diagrams can be drawn. Apart from cornea, please do not add any other details, like you've seen a lot of postgraduates adding the hypopyon, drawing a line inferiorly onto the cornea and shading with yellow. So all these things should be drawn in a slit section. Hypopyon, hyphema, AC reaction should not be drawn in the frontal view. So this is a simple diagram showing, I've shown how the hypopyon is to be drawn in the anterior chamber. You have to measure the height and to see the progress, whether the patient is responding to your therapy, becoming bad, or it's improving. Also the size of the stromal infiltrate and epithelial defect. So you have to mention both the horizontal and vertical or oblique diameter, whatever the lesion is, and also the vascularization, surrounding edema I have drawn. If you can see, I have drawn the entire lesion outline in green. That means the entire epithelial, there is epithelial defect within that lesion. So you should not fill the fluorescent stain or green color throughout the lesion. You should draw only the outline. That means the entire thing is taking up stain. In the slit view, mainly the cornea you have to concentrate. Front line is the corneal epithelium, and you have to mention the site where you are taking the slit, where you are drawing. And if the posterior surface is not visible due to edema, you make a dotted posterior line. Stromal thickness, if it is thick, it will bow behind. I'll show you all the pictures. The level of lesion is very important, especially to follow up and to plan for surgery. If the cornea is thin, mention in percentage. Normal cornea, if it is 100%, compare with the normal cornea above or below and mention the level of thinning, whether it is 50%, 25%, 10% or so. Descemetocele should also be drawn in slit view. Then anterior chamber depth is shallow, or if it is filled with blood or pus, you can draw. And also lens, vitreous and IOL. So here I have shown all the slit view. First is the normal cornea. This is the epithelium, this is the endothelium. Second, the posterior margin is not visible, so you draw on dotted line. And this picture, there is a lot of stromal edema, so it's bowing behind. And here there is thinning, almost 60-70% thinning is there. So you draw the original corneal thing to be in a dotted line, and this is the present situation. So this is area of thinning. You can always compare the cornea above. Here it is 100%, here it's 100%, it's around 50% or less than that. And this is the descemetocele, which is bulging forwards. And here I have drawn the hypopyon in yellow, pupil size, that is iris in brown, and lens there are posterior subcapsular changes. Here you can draw like this. So this is the infiltrate, this is the edema above and below. The slit view will give you overall a picture of the anterior segment. Vital stents, as I told, to be done in the end. SPKs don't fill in the entire cornea, as I said before, with the green dots. It should be more as close or as natural to the patient's condition as possible. So keep the case sheet near the slit lamp and then fill the area of interest. So measurements, that is all of you should be knowing how to use a slit height. You measure the maximum and minimum diameter of that lesion. Mention the shape of the lesion and landmark of measurement. That is which quadrant it is, whether central or eccentric, or if it's eccentric, it is occupying which quadrant the most. That is supranasal, supratemporal or others. Also maximum diameter and mark it with arrows. So follow the clock hour rule for perfect drawing. You can convert a cornea into 12 clock hours, and according to which clock hour you can draw this as a rough guideline and complete your drawings. Thank you very much.